Let's got it. Bismillahirrahmanirrahim. Today is my topic of the presentation is poliomyelitis. Today's message is when we replace I with the we, even the illness become wellness. So together we can eliminate poliomyelitis also. This is applicable to all public health problems also. Together we can replace illness with the wellness. So in today's my presentation about poliomyelitis, the learning outlines will be introduction, epidemiological determinants, chain of transmission or communicability, clinical manifestations, levels of prevention and recent advances, and what will be the outcome by the end of this presentation. We'll be able to understand about epidemiological aspect of poliomyelitis, preventive aspect of poliomyelitis, national and global updates, challenges and reasons for not being polio free so far, that we will cover today. So first of all, what is polio? Poliomyelitis is an infection of three types of viruses. Virus the most commonly invades the gastrointestinal tract, and viremic illness may develop. In some cases, the virus invades and destroys the anterior horn cell of the spinal cord. And this invasion results in the flaccid muscle paralysis, more commonly in lower limbs. In most severe cases, virus attacks the motor neuron of brain stem, causing difficulty in breathing, swallowing, speaking. In such cases, death can occur unless respiratory support is given. So here we see that the poliomyelitis is the disease of CNS, and in CNS we will see later on how the distinction is between the three types in the spinal bulbar or spinobulbar. Here you see that when the virus attacks the bulbar or brain stems where the peripheral nerves are involved, then they cause the difficulty in breathing or regurgitation or difficulty in swallowing. While the anterior horn cells are involved, then the spinal poliomyelitis may come out as an outcome. Here it is the picture of the polio virus. The RNA virus, single-stranded, and on the right side is the cross-section of the spinal cord showing the motor neuron of anterior horn cell and the gray matter. And polio itself is the name as a Greek word. Polios mean gray and myelos mean spinal cord. Mode of transmission of the polio, it's a fecal route, particularly where there is a poor food and water hygiene. In rare cases, droplet infection from the nasopharynx is also possible. In acute phase is more typical in areas where sanitation is good, like developed countries, and the incubation period is between 4 to 35 days, although more usually it's labeled as 7 to 14 days. Communicability is 7 to 10 days before and after onset, although virus may shed in the feces about 6 weeks or even longer. Poliomyelitis is thought to be first occurred in about way back 6,000 years ago, and the time of ancient Egyptians. Evidence in the history lies that we can see in the history that the deformed limbs of some of the Egyptian mummies. Let's talk about the agents of virus itself. Is structure. Virus, as I told you, a single-stranded positive sense RNA genome and a protein capsid. Genus is the enterovirus, and Picornaviridae is the family. There are three types: type 1, type 2, type 3. And it's in feces, it can survive up to years at 4 for months at 4 degree, and at minus 20 degree, it can survive for years. And it is rapidly inactivated by the heat and chlorination. Host range infection occurs only in men, as it, as I said earlier, is a mode of transmission fecal-oral and in early stages of the disease through inhalation or entry through the conjunctival droplets of respiratory secretions of the patients. Communicability is 10 days before and after the onset of the symptoms. And the host factor most vulnerable are 6 to 3 years. Male are more prone to this disease. The ratio is 3 to 1. Immunity first 3 months are protected by the maternal antibodies, and also the immunity is acquired through the infection with the wild polio, with the wild virus immunization. It's a seasonal, more usually during the rainy season, and contaminated water, food, flies, overcrowding, and poor sanitations are the environmental source of infection. Let's talk about the levels of preventions. First is the health promotion through environmental sanitation and health education, teaching about the people, talking about the people, giving information about the mode of spread and how protective is the vaccine available to us. Then we talk about the polio surveillance. Two types of surveillance are being carried out for its prevention. First is acute flaccid paralysis surveillance, and second is the environmental surveillance. Acute flaccid paralysis surveillance, AFP surveillance, is the finding and reporting the children with acute flaccid paralysis and transporting the stool from samples for analysis and isolating the virus, and then the mapping of the virus on that particular geographical area. What AFP case is meant by, I mean, when we can label the AFP case, any sort of paralysis, flaccid paralysis under 15 years of age with no obvious cause such as trauma or electrolyte imbalances found, paralytic illness, or any paralytic illness in any age where polio is suspected will be labeled as the AFP case. In environmental surveillance, we do surveillance and the sampling of the sewerage water or environmental sample from other places for the presence of poliovirus. A few words about how the reporting protocols are for conducting the AFP surveillance. All reported cases of acute flaccid paralysis should be investigated by the district surveillance coordinator within 48 hours after notifications. 2 stools are taken at least 24 hours apart and collected within 14 days of the onset of paralysis, and maximum within the 8 weeks. And then the outbreak response immunization is done. In outbreak immunization, response immunization, children under 0 to 59 months are given 1 dose of OPV, regardless of previous immunization in a village or locality. And the travel history of the children with the AFP may suggest additional place of stay where outbreak response immunization should also be conducted. Reporting protocols for AFP cases: active search in the community where AFP cases reside or where AFP case has visited during the incubation period for polio, that is 4 to 25 days before paralysis onset, or a house-to-house active case search is conducted to find additional AFP cases. The activity is carried out immediately along with the outbreak routine immunization. A research is conducted for any children less than 15 years who have had the onset of AFP within the preceding 60 days. And all cases are found investigated immediately with the collection from the case of 2 sample specimen before administration of OPV. Stool examination is the keystone for the isolation of the virus and diagnosis. Isolation polio, a wild polio virus from the stool is the recommended method of laboratory confirmation of paralytic poliomyelitis. It's recommended in every case of AFP. It's a virus usually can be found in the feces from onset to up to less than 8 weeks after paralysis, with the highest probability of detection during first 2 weeks of the paralysis. Stool is carried from the periphery to central uh, WHO accredited lab where the while observing the cold chain, and that's called the reverse cold chain when the stool is taken from the periphery to the center in the same temperature, like 2 to 8 degrees centigrade, uh, where the vaccine is stored at that temperature. Here is the bifurcation of infection. You can say that there are two major categories. There may be inapparent infection and clinical infection. Uh, in clinical poliomyelitis, we see again two types: abortive poliomyelitis or minor illness, and the involvement of CNS where there is a major illness. And again, involvement of CNS, there are two types: uh, non-paralytic polio and the paralytic polio. In paralytic polio, we further subdivide spinal, bulbar, and bulbospinal. In spinal, the spinal cord, when the anterior horn cell of it's a sort of a uh, anterior horn cell of the spinal cord are involved. Lower motor neuron lesion occurs, and the muscles or the trunk or the abdomen these are involved. In the bulbar polio, the cranial nerves are involved, and the manifestation may come out in like regurgitation, dysphagia, or nasal twang like this. And bulbospinal is the combination of spinal and bulbospinal polio. Uh, Most common of these is spinal polio, and 80% of the cases are spinal polio, and 20% are bulbospinal. And rarely, bul, bul, only the bulbar form is the very rare form of the poliomyelitis. Let's talk about the symptoms briefly. It's a highly infectious disease. It's invades in nervous system and causes a total paralysis in a matter of hours. Virus is transmitted by person to person, mainly through fecal route and less frequently by common vehicle like contaminated water or food, and multiplies in the intestine. Initial symptoms: fever, fatigues, headache, vomiting, stiffness of neck, and pain in the limb. And 1 in 200 infections lead to irreversible paralysis. Among those paralyzed, 5 to 10% die when the breathing muscles become immobilized. Clinical manifestations: a small number of people with poliomyelitis will develop other more serious symptoms like that affect the brain and spinal cord, which may include paresthesia, meningitis, and paralysis. Even the children who seem to have recovered fully from the disease or paralysis, when they grow up, like 15 to 18 years later, they may develop a new muscle pain, weakness, or paralysis, and that sort of situation is labeled as post-polio syndrome. And poliomyelitis is defined as a paralytic disease. Only the people with paralytic infection are considered to have the disease. And these are the manifestations of poliomyelitis, what polio can do, the deformities of the limb in the various, the age group. As far as prevention is concerned, there is no cure, but only the vaccine which can protect the child from life. You can see that I will talk about the vaccine. You can see the picture of the polio vaccine vial. It has a monitor on it, vaccine vial monitor. It's a 20 ml vial, a 2 ml vial with the 20 doses in it. Poliomyelitis, it's a type. First, we'll talk about the OPV. It's active vaccination with the live attenuated virus in oral polio is the sapin or OPV, and while the injectable form or inactivated virus uh, vaccination is called IPV or the Salk vaccine. As far as the OPV concerned, 3 doses are given, and booster 2 doses. Adverse associated with the oral polio vaccine is 1 into 1 million, and uh, while with the IPV, the country indication with the OPV is the acute febrile illness, vomiting, diarrhea, malignant disease, immunocompromised position, or pregnancy. While in IPV, we don't give the during acute febrile illness. This is, here you can see we are simultaneously using two type of vaccine in our EPA program. We give usually the 4 doses of OPV, 0 dose as soon after birth, 6, 10, 12 weeks, and along with the OPV, IVP injectable inactivated poliovirus vaccine is also given at the 14th week. Why will give it? I will discuss it later on. As you can see, during polio campaign, the left little finger is marked with the marker so that the child may be recognized that he has been vaccinated. The most common problem why you can see, we will discuss later why we haven't been able to eradicate the polio so far. The scattered population, nomads, or this population residing in the camps or the periphery or uncounted people there. Here you can see that there are 4 circle with a rectangle inside. When the rectangle is lighter, you can use the vaccine, while it is going to have the same color with the surrounding circular. We recommend to use this vaccine first. But if it's coincide with the color of the outer circle, we don't recommend it. Or if it becomes darker, we also don't recommend it, or it is to be discarded. Here comes the little comparison between OPV and IPV. OPV is the live attenuated virus, while the IPV is the killed virus. Route of administration is in OPV is oral, while IPV is given subcutaneous intramuscularly. OPV gives the humoral intestinal immunity, while IPV gives the only humoral systemic immunity. OPV prevents not only the paralysis but also intestinal reinfection, while the IPV can only prevent paralysis. But advantage of the OPV is effective in epidemics, while IPV is not. It's cheaper to develop OPV, but IPV is quite expensive. And vaccine-associated paralytic polio is 1 in 1 million in OPV, while there are no chances of vaccine-associated polio paralysis in IPV. Here are a few key facts. Poliomyelitis affects under 5-year-old children. 1 in 200 infections lead to irreversible paralysis. Among those paralyzed, 5 to 10% die with the breathing problems. Cases due to wild polio virus have decreased by over 99% since 1988, from 350,000 cases to only 33 reported cases in 2018. As long as single child remain infected, child in all countries are at risk of polio. That's why we focus on the collaborated efforts. Failure to eradicate from these last remaining stronghold would result in as many as 200,000 new cases every year within 10 years all over the world. Here you can see that the percentages of outcome of this infection, 95% are inapparent or subclinical, abortive polio, minor illnesses 4 to 8%, non-paralytic 1%, and paralytic polio, or you can say the descending asymmetric classic paralysis occurs in less than 1% cases. Global eradication campaign and national immunization have been carried out in 28 countries, and over 140 countries have now conducted surveillance for the cases of acute classic paralysis. All countries involved in polio eradication have undertaken mass campaign using OPV followed by mopping up activities and house to visit in the area where the cases exist. The incidence of areas in the world are becoming free of the disease, while success in the site zones and countries where there is an armed conflict remains difficult to implement effective immunization program. The challenges ahead for the polio eradication is that since the Global Polio Eradication Initiative, GPEI, this was established in 1988 with two of the three polio viruses, serotype 2 and 3, have been eradicated. Transmission of wild poliovirus type 1 remains uninterrupted only in Afghanistan and Pakistan. In 2019, Afghanistan and Pakistan reported the highest number of wild poliovirus 1 type case since 2014. Paralytic poliomyelitis can also be caused by circulating vaccine-derived poliovirus, which emerges when attenuated oral polio vaccine virus reverts to neurovirulence following prolonged circulation in the under-immunized population. So you can see that the global withdrawal of the type 2 containing OPV in 2016, the circulating virus, vaccine-derived poliovirus type 2 outbreaks has increased in number and geographical context, in the geographical context. During January 2018 to March 2020, 21 countries reported 547 circulating vaccine-derived poliovirus 2 cases. Complication, all of these factors have been complicated in 2020 due to COVID-19 pandemic, and mitigation effects have resulted in suspension of immunization activities and disturbance of polio surveillance. There are the reasons why we have been not able to eradicate the polio so far from our country: the overcrowding, poor sanitation, inaccessibility, extensive population movement, suboptimal campaign, routine immunization, low routine immunization coverage, pockets of refusal, significant changes in the health manpower, and sharing free border with Afghanistan. These are the few of the, the reason that we are not able to eradicate the polio so far. And you can see that the global polio eradication efforts are going on. That there have been 3 phases from 1988 to 2000 and 2016. You can see the red areas where the polio have been prevalent and have been decreasing worldwide. The yellow patches showing the cases which have been imported to that area. And this is the figure till 2016. And till 2020, we have been able to achieve the vaccination coverage of OPV and IPV. OPV is 75% and IPV, both for OPV and IPV, Pakistan has been achieved to able to cover the 75% of the population. As the figure showing the comparison, the number of cases, Pakistan still have the 2,209 cases till March 2020. And here you can see the 2 type of viruses, poliovirus type 1 and circulating vaccine-derived poliovirus. Still, these are prevalent in Afghanistan, Pakistan, and Nigeria. Here there are another table showing the how many percentage of isolates and the number of samples taken. Still, Afghanistan and Pakistan are on the top. Rather, Pakistan is having the worst figure than even the Afghanistan. Here is the summary of what we have seen so far. Wild poliovirus 1 type transmission continues in Afghanistan and Pakistan. Circulating vaccine-derived poliovirus outbreaks occur in areas where there is a low immunization coverage. Although wild poliovirus type 1 incidence declined annually during 2015 to 17, cases in Afghanistan and Pakistan have increased since 2018. and a number of geographical spread of circulating vaccine-derived poliovirus type 2 outbreaks are increasing. COVID-19 pandemic has resulted in suspension of immunization activities and disturbance of polio uh, surveillance. The implication on the public health practice is that substantial effort to address pragmatic challenges are essential to safely restore and scale up the polio field activities in 2020, including a use of stabilized type 2 viral or type 2 oral polio vaccine to prevent the new circulating vaccine-derived poliovirus to emergencies. That's all about the, I mean, its disease and the present situation. Here come the MCQ now. The region where the poliovirus multiplies in the body is
intestinal tract.
reverse cold shade is seen in the in polio immunization program VVM vaccine while monitoring maintained to cold shade. The following is the indication to discard the vaccine.
D.
C.
C.
Which of the following is not true about the oral polio vaccine?
D.
That's not 10 in 1.
It's 1 in 1 million.
That's 1 in 1 million. Correct statement regarding vaccine of polio is
B.
when the global polio eradication
1988.
that's 88. Environmental surveillance is
Second.
E. Primary prevention.
that's primary. The action taken prior to the onset of the disease is environmental sampling would be sampling of the sewerage or water sampling in the slums area, so that we can take the otherwise like the campaign about polio can be carried out in that particular area. That's primary. Sorry. OPV is stored at what temperature?
C.
+2 to +3.
Paralytic polio or descending asymmetric flash occurs in
Less than 1.
D.
less than. And how many doses are in a single
20 doses.
20 doses in 2 ml.
20 doses 2 ml. Yes, see. That's C. And these are the keys and references for today's presentation. That's all about from me.
Thank you very much. Please announce the results, Dr. Daud.
All of us have contributed to Dr. Maida, Saidia, Mehreen, Amber, and also Khansa.
Okay, next time please also make a record that how many of the students have given the maximum good answers, right? Very well elaborated and very well organized presentation. You have started with very basics of polio, and slowly you build it on, and you come to the very complicated discussions, especially about the vaccines and the types, serotypes, and how different countries have eradicated Pakistan and Afghanistan are two of those countries where eradication programs have not been successful. One thing is very important that you have already talked about the spinobulbar type of poliomyelitis. Yes, it is a very common, and we know that many cranial nerves, their centers are in bulbar area. So it is the spinal as well as the bulbospinal area where the poliomyelitis can affect, and it can have a lot of presentations. We all know that the asymmetrical paralysis of lower limbs that has always raised a question, and we always investigate in favor of polio, but there are also other presentations. The second important thing that you have talked about is about the number of the cases. According to 22nd December 2020 official report, Pakistan has 84 cases of polio. In 2019, there were 147 cases. So we are still having many cases. And how to achieve eradication? As you know, that WHO has projected the data and they have shown that in 2000 we would be able to eradicate polio from the world, including from Pakistan. So it is something that is really worrisome that in even 2021 we still have the cases of poliomyelitis. So there are many things that has to be considered while we are dealing with so many cases of polio, and we are very hopeful that in 1 or 2 years we would be able to eradicate polio. But how? The actual question is how. As one of the strategy that we have very advocate very well in different meetings is about having more emphasis on IPV. That is a killed vaccine for polio. It is given in the form of the injections, and it is one of the vaccine that can produce good results. The second important thing is about vaccine diplomacy. I would ask my students if anybody would tell us more about vaccine diplomacy. Dr. Daud, would you please shed some light on vaccine diplomacy?
I haven't heard about this term, the vaccine diplomacy, but what I can perceive is that as we have withdrawn the polio type 2 vaccine and have introduced the IPV there, and we are going to replace the OPV with the IPV once we have attained the eradication there. I don't
Okay,
know.
Dr. Daud, we once had a lot of discussion in the department, and I remember that you were also there when I said that at that time, a few years ago, we were doing a lot of advocacy for IPV vaccine. We were going to the meetings of different vaccination programs, and we were continuously advocating, or we are doing advocacy for having IPV vaccine, and that is one of the doable option. The second thing that we have been doing advocacy for many years is about vaccine diplomacy, and we strongly believe that all the countries, especially Pakistan and Afghanistan, they have a better diplomatic relationships. They must have more coordination and collaboration. Without coordination and collaboration with other countries, perhaps it would be very difficult or probably impossible to eradicate polio from these two countries. And here the vaccine diplomacy can play its role, that we have a coordinated effort to eradicate polio from these countries. The Another important example of vaccine diplomacy has occurred in COVID-19. As you have seen, that all the countries, they know it very well, that if the vaccine is being offered to only those countries where it is being produced or who can afford it, then we would not be able to eliminate COVID-19 or decrease the disease burden of COVID-19. It is one of another example of how vaccine diplomacy is working, and how other countries are being offered help in giving vaccine so that they can also contribute in decreasing the disease burden of COVID-19 from the world. Similar is the case with polio. As we know that smallpox has been eradicated from the world, and now it is only present in 2 laboratories in 2 countries. Similar is the case with polio. Soon it would be eradicated only and only if people would realize that if a single case of polio is being reported from any country like Pakistan or Afghanistan, then our dream of having polio-free world would not be possible. So there is a lot of vaccine diplomacy that is going on, and we have to do more advocacy about vaccine diplomacy. Overall, it is a wonderful presentation, and there is how the things have been given with evidence, especially recent evidence. It is wonderful. If anybody has any question, you are most welcome to ask. Okay, Allah Hafiz.
Allah Hafiz.